renal failure, we probably won't treat them because we do use iodinated contrast, and there's a good possibility that we'll make their kidney function significantly worse, at least transiently. We have done things for patients with renal failure and contrast allergies to pre-medicate them when we think that their level will tolerate contrast exposure. Patients who are severely debilitated, this is a very, very difficult, this is a judgment call. It's very, very hard for us to make that decision over the phone. We've had very, very few patients, I think one that I'm aware of, who got to us and we found out that the patient had a systemic illness, an infection that was causing high fevers, a history of bacteremia, in other words, bacteria in their bloodstream, and we hadn't been made aware of it, and we didn't feel comfortable moving ahead with the treatment until the infection had been cleared because we were afraid that anything that happened during the procedure could potentially be confused with causing an infection, and then they would treat the patient in the wrong way. So we have reasons why we don't, but I have to say it's very unlikely that patients meet any criteria that would make them not someone we would consider for therapy. Our staff can handle most situations. I'm not going to go into this in too much detail because I think the video is going to show you most of this, but this is our care protocol. I guess the one thing I would say here that I think is important is that I think patients should at least meet their operating physician the day that they have their procedure done. I think it's very important that they say hello, that if nothing more, they'll recognize the voice that's in the room with them, all covered up by a blue mask at the time of the procedures being done. I also think that we need to do some sort of follow-up. I don't think that just leaving the room and then never hearing from us again makes any sense. We make a phone call the day after the procedure. We make a phone call at 1 month, 3 months, and 6 months, and we think it's important that we try to get an ultrasound at least at 3 months. This is actually why I think the rate of jugular thrombus, clot forming in the jugular vein, and I'm not talking about occluding the jugular vein, but clot forming in the jugular vein, this is why I think it's higher than people are talking about, because most institutions do not perform an ultrasound at 1 month, 3 months, and 6 months, or ask for one. And I think that there are probably subclinical, in other words, little clots that are forming that no one ever knows about because the ultrasounds aren't being done. We'll see. I mean, you know, the jury's still out on how realistic that is. What's our experience? We did review our first 400 patients, and looking at our first 400 patients, we are seeing approximately 66%, 2/3 of our patients have a subjective improvement by self-administered scales. Most of their improvement is in the typical symptoms that people with MS describe as responding to CCSVI therapy, things like temperature and sensitivity, fatigue scales, bladder dysfunction. We have had the occasional, really what I would describe as a grand slam. I'm not a baseball fan, but I mean, realistically, sometimes things are just, it's shocking, the response that patients get. Those are the patients who, fortunately or unfortunately, get on the video and become famous for how much they responded. I think it's great, but I think it's tough because we tell these patients, please make sure you tell everybody that we're hoping you get that response. We just don't know. We don't know how much people are going to respond. Only 17 of our cases were repeat treatments. Those are the places where we tend to end up seeing patients who need to have stents. So that's a very small number, and I expect that that number will probably increase significantly. 3 of our patients, or 1%, required stent placement. And as I said, we have about a 6.5% rate of internal jugular vein clot. So that's it as far as the nuts and bolts, the theory, what we know, what we don't know, the data that's out there, how we do it at Rhode Island Vascular Institute, which I think is similar. What I'd like to do now is show you about a 10-minute video clip. I know it's getting late, so if you guys want to grab the water or coffee or something, and then I can play the video, we can do it that way, or if you want me to just go on, we can go on with it. And then once the video's done, I'm just going to stick around as long as we have questions to answer.
Before you do that, can I throw a couple things at you?
Sure thing.
There's a couple things that we need to dispel that have been misstated by the medical people in our country and by the government. There's a couple things we need to dispel. We have to. First of all, I'm going to go backwards with this a little bit. What is your restenosis rate? I know you put that up there, but what is your restenosis rate from your procedures, approximately?
Between 40 and 50%.
Okay.
And that's really not a fair number to put out there without looking at your total N, because in order to know the fraction, you need to know the numerator and the denominator very well, and we haven't reviewed all of our charts to say that.
Okay.
But for the patients who we have data on, it's around 40 to 50%.
How often do you use stents?
1 to 3%, so very few. So, around 17 of our patients we've used stents. Small number, very small.
The Doppler exams, they're being done by Barry Vascular Clinic by Sandy McDonald under an IRB from the States that was gotten from Foundation. He's got 2 different IRBs, so our people will be followed up at 1 month, 3 months, 6 months, and a year.
Yeah, I think that's crucial. And you know, one thing I would like to point out, Dr. McDonald is, I have to say, he's an amazing guy. Anybody who gets a chance to talk to him, you really should take the opportunity. But he follows most of our patients who are from the area, from this area. And when I say this area, I guess I mean within about 6 hours of here. I mean, he's really good about, our patients can't get ultrasounds in a lot of situations, and he's always willing to take patients for their ultrasonography and show us. And his reports are excellent. Everybody who's doing a lot of ultrasonography, if they haven't been trained by him, they're trained by the people who were trained by him, and all of their reports are being structured in such a way so that they emulate what his reports tell us. They're really the only reports that make a lot of sense, unfortunately, the ones that you get from his office. So.
There's no fear of lack of follow-up with people that are in this area. Definitely. He's made sure of that, so do not concern yourself with that. Before you go through the procedure, book your ultrasound follow-up with very vascular clinic, and they will do it properly.
So do you guys want to just start firing questions, or would you like me to play the video? Really, it's up to you. I know it's been a fairly long talk already. Want to hit the video and get it over with, and then we'll go questions? Great. All right. As you arrive at 690 Eddy Street in Providence, you will notice ample free parking with access for all levels of mobility. Steps away from the front entrance, you will see conspicuous signage directing you to the elevator, which will bring you down 1 flight to the garden level where the Rhode Island Vascular Institute is located. Patients are greeted at our front desk by the friendly staff and any intake paperwork completed. Depending on whether or not you've had an ultrasound recently, an ultrasound and Doppler evaluation of the jugular veins will be performed by one of our registered vascular ultrasound technologists. This ultrasound can be helpful in directing us toward the vein most likely to be abnormal. Though many patients will have had phone consultation before arriving at the Rhode Island Vascular Institute, most patients will meet their operating physician at the time of their arrival. This allows us to perform a brief history and physical examination and to discuss the procedure in detail with patients and their family members. At this time, we also entertain and answer any remaining questions and concerns before the procedure. Next, one of our experienced registered practical nurses will place an intravenous line. This will be used for medications and fluid during the procedure. We feel that though the procedure is minimally invasive, a small amount of sedation makes the experience less anxiety-provoking and comfortable. Once you have received any type of medication, your vital signs, including your oxygen levels, heart rate, blood pressure, and temperature, will be monitored throughout the procedure. At this point, you will be transported into one of our specially designed and equipped angiography suites. Once comfortably positioned on the angiographic table, you will be prepared in sterile fashion and covered with a sterile drape. Only a small area in the upper thigh will be left exposed to allow us to perform venous access. After sterile preparation and draping, ultrasound guidance is used to obtain access to the femoral vein in the upper thigh. Ultrasound access allows us to minimize any possibility of complications during this portion of the procedure.
The Seldinger technique, which was pioneered by angiographers, the predecessors of interventional radiologists in the 1950s, is used to allow us to perform all interventions through a single access in the femoral vein. The Seldinger technique entails placing a wire through a skinny needle and then gradually and sequentially upsizing the access site to allow our working devices to be placed through the same needle access. Using the Seldinger technique and ultrasound guidance allows us to perform nearly bloodless access to the body's natural highway system, the venous anatomy. Once we have accessed the venous anatomy, we use our knowledge of normal venous structures and X-ray guidance or fluoroscopy to steer our specially designed catheters and wires through the venous system into the blood vessels of which we have concern. The techniques we use for accessing and imaging the venous system for treatment of CCSVI have been perfected over many years and through thousands of venous procedures by our interventional radiologists. Often during the procedure, we need to carefully adjust the angle with which we image the veins so that we have the exact projection to allow us to identify any abnormalities. Here you see a catheter within the azygos vein, the candy cane-shaped structure located behind most people's hearts. This diagnostic venogram gives us important information about the flow of blood within the vein. Once we have exactly located the abnormality within the vein, we exchange our diagnostic catheter for an angioplasty balloon catheter over the same wire and through the same access. Using fluoroscopic guidance, the balloon catheter is then placed to the level of concern. A specially designed inflation device, which allows us to carefully monitor the amount of pressure delivered to the balloon, is attached